Hi, I'm Dr. Dermot Kelly, one of the consultant anaesthetists in the Royal Victoria Eye and Ear Hospital here in Dublin, and I'm going to take you through a short video on peribulbar ophthalmic block, which is a very useful block for both anterior and posterior chamber work, and we'll go through it on a step-by-step basis. For the peribulbar block, we attach routine monitors, a couple of drops of proxy in the lower eyelid as shown, and then I like to swab the skin with an alcohol swab where we're going to inject along the orbital rim. So next off, we get the patient to put their eye in the primary gaze. The nurse puts a hand on the forehead to stabilize the head, and the patient is asked to focus both eyes on the nurse's finger straight in front. So I've 5 mils of 2% lignocaine. It's a 23 gauge needle, 25 millimeters in length. And I orientate it so the bevel faces towards the cone of the muscle, so the injection will be carried in towards the cone and the nerves. So feeling the orbital rim, level with the lateral limbus, you inject with the 10-degree angulation as shown. This is the same as the angulation of the orbital floor. With the eye in the primary position, you pass the 25 millimeter needle back, aspirate back to make sure there's no blood, and slowly inject. There should be no resistance to the injection. As you can see, the upper eyelid starts to come down quite quickly, and there's a little bit of lateral swelling and chemosis consistent with the peribulbar block. So you inject. I like to go for 4.5 or 5 mils of 2% lignocaine. Obviously depends on the exact surgery we're doing. And withdraw the needle. There's no blood in the needle, as you can see. Very avascular injection. And the patient is asked to gently close his eyes and firm pressure is applied. It's often a little bit uncomfortable for the patients at this point as the local starts to act. And you maintain digital pressure for about 60 to 90 seconds and reassure the patient at the same time monitoring the vital signs. So here we are at 60 seconds. You can see there's a degree of facial nerve block, and we ask the patient to follow, and you can see that there's very little movement on the right side, so there's quite good akinesia from this block. Patient cannot look inferiorly or superiorly, and you can see that the upper eyelid on the right hand side has come down, and this is very useful as there'll be very little blepharospasm during the surgery because of the facial nerve block you tend to get with peribulbars. So again, very good akinesia and very little swelling.